E. You pick up your diabetes meds. Your A1C is finally trending down, but in the bedroom, your full strength setting feels like it got switched to dim and nobody sent a memo. Great for health, sure, but if the tent pole isn't pitching like it used to, it's time to ask a brave question. Is your diabetes med quietly taxing your drive? This isn't about quitting treatment. It's about flipping the right switches so your health plan and your sex life stop fighting each other. I'm Dr. Amelia Hayes, urologist. And today, you'll get a laser-focused self-assessment to see whether your medication, dose timing, or side effects are stepping on your libido or your water pressure. Stay to the end for an easy 2-week plan, and the exact phrases to use with your doctor to protect both your numbers and your nights are: men with diabetes face about a 3.5-fold higher chance of erectile problems than men without it, which means you start the game down a few points even before medications enter the picture. The reasons stack up: vessels get stiffer, nerves less snappy, hormones can drift, so anything that adds fatigue or sleep disruption can push desire and firmness over the edge. The good news is that the same levers that help your heart and A1C can also lift erection quality if you set them right. A lot of men assume that any weight loss med will supercharge sex automatically, but responses are mixed, especially with the popular GLP-1 shots. Signals from large health record datasets suggest a small but real uptick in ED diagnoses among some non-diabetic men on semaglutide for weight loss, even though absolute rates are low. At the same time, other data and mechanistic work show potential upsides for sexual function through weight loss, better vessel health, and metabolic improvements, particularly in men with diabetes and obesity. Translation: GLP-1 second can be friend or frenemy, your context, dose, side effects, and schedule. Decide which. Think of erections like household water pressure. Diabetes lays some rust in the pipes, and side effects like nausea, fatigue, or poor sleep twist the faucet tighter. If your weekly shot leaves you drained on dose day and the next morning, that's not your masculinity. It's a predictable low-energy window you can plan around. If evening reflux or jittery sleep shows up when you stack meds with late caffeine, desire doesn't vanish, it gets drowned out by noise your brain prioritizes. The fix often isn't dramatic, it's lining up the green lights so mood, energy, and circulation peak when you want them to. Diabetes raises the ED baseline, and your meds can either pull you up or push you down depending on how you time, pair, and tolerate them, so your job is to identify the friction and remove it. Answer these out loud or jot a quick score. If you hit 3 or more, yes, it's time to optimize with your clinician. Do you feel distinctly more tired or less motivated for 24 to 48 hours after your weekly GLP-1 dose? Has your libido dipped mainly on your dose day or the day after, then bounced back later in the week? Are nausea, early satiety, or constipation making you avoid intimacy because you just don't feel great in your body? Did you start or increase a diuretic or certain older beta blockers around the time your erections got weaker? Do you drink caffeine late to fight GLP-1 fatigue, then sleep poorly and feel flat the next morning? Have you noticed ED more if you're non-diabetic and taking semaglutide purely for weight loss? Has morning wood declined even as your A1C improved, suggesting energy and sleep, not sugar alone, are sabotaging desire? Sen. If your yes answers cluster around dose timing and low energy, shift the shot to a day that protects your best intimacy window and consider a lighter next day schedule. If nausea or GI issues dominate, work with your prescriber on dose titration, slower escalation, and meal timing so your body stops fighting the plan. If blood pressure meds changed recently, ask whether an equally protective option with fewer sexual side effects suits your profile. If you're non-diabetic on semaglutide and notice new ED, discuss risk, benefit, and alternatives like lifestyle plus different agents while you stabilize weight. Take your GLP-1 on a morning that doesn't collide with your usual date night. Schedule intimacy on your highest energy days 48 to 72 hours later. Pair the dose with a bland, protein-forward meal to blunt nausea and avoid big, greasy dinners that amplify GI side effects. Set a hard caffeine cutoff in early afternoon and keep electronics out of the bedroom. Better sleep is jet fuel for testosterone rhythm and desire. Add 2 brief resistance sessions weekly, think bands, goblet squats, and push-pull because muscle mass supports glucose control, mood, and erection quality. My A1C is improving, but my erections and libido dipped after starting up titrating med. Can we look at dose timing, slower titration, or an alternative with fewer sexual side effects? If you recently started a diuretic or certain older beta blockers and noticed ED, ask about alternatives with a more neutral sexual profile. If ED began on therapy, discuss the observed risk signal, keep perspective on the low absolute rates, and explore whether a pause, switch, or adjunct strategies make sense. You don't have to choose between a lower A1C and a higher libido. Most men get both by changing the when and with what, not the whether. Energy often improves within 1 to 2 weeks after dose day changes and sleep fixes, with libido following as you feel physically better and more confident. Erection quality tends to respond over 3 to 6 weeks as you stabilize training, sleep, and med timing, log morning wood and shim scores to see the trend instead of guessing. If you're non-diabetic and noted new ED after starting semaglutide, a conversation about alternatives may produce improvement in a similar 4 to 8 week window. Are GLP-1 bad for sex? Not universally. Some men see better function with weight and vascular gains. Others, especially non-diabetics, may see ED. Context and tolerance matter. Will losing weight help erections even if a med caused a dip? Often, yes. Lower inflammation and better vessels lift confidence, provided energy and sleep are protected. Can metformin reduce testosterone? Some data suggest testosterone metrics can dip on metformin in certain contexts, but overall metabolic health still helps erections. Ask if your broader plan needs balancing. What if I'm on a diuretic? Diuretics can be ED unfriendly for some. Do not stop on your own. Ask about alternatives that still protect your heart and kidneys. Should I add a PDE5 pill now? Discuss it. It can be a bridge while you optimize timing, sleep, and side effects, but always with your clinician's guidance. It numbers A 58-year-old moved his weekly GLP-1 shot to Monday, protected Friday and Saturday, shifted caffeine earlier, and by week 2, his partner noted the old spark at brunch. A 62-year-old swapped a diuretic under his doctor's guidance and kept up light lifting. Both blood pressure and bedroom confidence hit their stride again by week 6. A 65-year-old non-diabetic paused semaglutide after new ED emerged, refocused on resistance training and nutrition, and saw erection quality rebound while holding most of his weight loss. Write down your dose day, the next 48 hours of energy and GI symptoms, and your best intimacy windows. Set a 2 p.m. caffeine cutoff and a 10 p.m. wind down so sleep stops sandbagging your hormones. Book a medication review specifically to discuss sexual side effects and alternatives that keep your A1C plan intact. Add 2 20-minute resistance sessions this week. Keep it simple and repeatable. You are not broken, you're adjustable. And the map to better erections at 50, 60, and beyond is the same one that protects your heart and brain, sleep, strength, smart meds, and honest conversations. This content is educational and not medical advice. Never stop or switch prescription drugs without your clinician, and if ED persists, see a urologist to rule out cardiovascular red flags and get a personalized plan.